Chapter 21, Resuscitation. How do we bring people back to life? Start off with the pathophysiology of a cardiac arrest. What is it? How does it happen? And then we will learn how to fix the problem. We all know the heart functions to pump blood throughout the body. This is caused first by the electrical function causing the muscle to contract, and then the actual muscles contracting to force the blood through the body. What we're so forcing through the body is oxygenated blood. Without that oxygenated blood, the heart doesn't have the ability to create its own energy to pump the blood. So mechanical failures, loss of the muscle tone, loss of the muscle structure, that could be from a acute coronary event that causes decreased blood flow to the coronary muscle in the form of a myocardial infarction. Could be chronic hypertension. The heart just gives up because it pumps so hard. Loss of normal heart valve function. So when we push blood out, instead of going out, it goes backwards in the system because the valves are dysfunctional. Could be some type of trauma that causes damage to the muscle of the heart. And then we also have a lack of communication or lack of reception of the electrical activity in the heart called pulseless electrical activity, or PEA. It means the electrical signals are going through the heart just like it should, but the muscle is not recognizing those signals and responding to them. So the electrical dysfunction, something in the pathway has gone wrong. The SA node, the AV node, the Purkinje fibers, bundle of His, something in that system has caused a malfunction. Asystole is a complete malfunction. There is no signal going through the heart anywhere. Other problems could be some type of dysrhythmia, of malfunction in the conductivity system, and the heart is not picking up the signal correctly or reacting to the signal correctly. So it could be too slow. If it's too slow, then you don't have the cardiac output you need. If it's too fast, then you don't have the ability for the blood to pick up the oxygen in the lungs, and it just keeps flowing around, so you don't have that gas exchange occurring. We have two ventricular problems that could result in the cardiac arrest. One would be ventricular tachycardia. That's where the ventricles take over and start beating over 100 to like 150, 200 times a minute. This is way too fast for it to actually fill and contract. And then we have VFib, where the muscle quivers within inside the heart. These all lead to sudden cardiac arrest, where the heart is just comes to a standstill. VFib and VTAC, these are the two that we can correct with an AED, and that's why AEDs are so important in the community. Sudden cardiac arrest. It's an abrupt onset of dysrhythmia. This could be precipitated by some type of myocardial infarction or some type of other trauma. Could be blunt force trauma to the chest, a condition called commotion cordis. This is where you see the shirts that youth baseball players wear that have the little strike pad in the center of the chest. That is preventing this condition from happening. If you get a sudden blow to the center of the chest at just the right time, it can cause your heart to go into sudden cardiac arrest. The good thing, the reason why we have good survival from sudden cardiac arrest is because the heart just stops. The oxygen levels are fairly normal when it starts, so we can recommend hands-only CPR because your body still has oxygen in the blood. We can get the heart restarted quickly by stopping the bad rhythm and letting it take over, letting it go back to a normal rhythm. So we've got lots of opportunities here because it's such a sudden occurrence. The asphyxial cardiac arrest, this is when the heart runs out of oxygen. You have some type of cardiac or respiratory event that causes hypoxia, the blood levels of oxygen drop, and then you lose your ability to contract the heart muscle. Ventilations on this type of cardiac arrest are really important because we got to get that oxygen going back into the heart muscle. So these are the more less common types of cardiac arrest for adults. With kids, this is the most common type of cardiac arrest because they don't have heart disease, which causes the sudden cardiac arrest. They have more asphyxial cardiac arrest because they have respiratory problems that deprive the heart of oxygen, and it slows down and gets to the point of not beating anymore. That's why ventilations are so important in kiddos and adults. We can do the hands only. Agonal respirations. Agonal respirations occur as the body's trying to get that one or two last breaths in to try to restart everything. The medulla sends out a signal to the respiratory muscles and says, "Hey, you better take a breath, or we're all gonna die here." So you take these real deep gasping breaths. They're not really functional. They don't get oxygen into the lungs enough to cause a change in the condition, but they provide a good. They provide some last-ditch efforts to try to get something in. But what we want to make sure is we're not confused by agonal respirations being real respirations. So got a little video we're going to show you that kind of shows how this function works.
Hi, it's Stephanie again. Agonal respirations are not considered normal breathing. The patient may be gasping or gulping. Agonal respirations are a sign of cardiac arrest and may occur in up to 40% of cases. Agonal breathing is caused as the brain becomes hypoxic, which means that it's lacking oxygen. The patient is not exchanging air well and requires aggressive resuscitation attempts. It is important to recognize abnormal respirations when performing CPR and giving rescue breaths. Most laypersons do not know how to identify agonal respirations and may misinterpret them for normal breathing. If the rescuer is unsure about the respiratory effort, they should assume the victim is not breathing and begin intervention. EMS is trained to recognize agonal respirations, and they can assist rescuers in determining abnormal breathing during an emergency. This concludes agonal respirations. Thank you for watching.
So that gives us an idea of what agonal respirations look like and how they kind of function within the body. The effects of cardiac arrest. The heart fails to pump. So if it's not pumping, you're not circulating blood, you're not circulating oxygen, you're not retrieving the nutrients and giving them to the end organs. You're not getting the waste product removed from the body. Organs become damaged because of this change in the homeostasis. Eventually, organs start to fail. The kidneys are our first one that being without oxygen and without blood flow causes a serious problem. If we don't fix this, the patient will die. So you can only go better from a cardiac arrest. Our goal is to get help to them as soon as possible. And we're going to talk about the chain of survival, and that's one of the goals of the chain of survival is getting the help there as quick as possible so that we can solve the problem and prevent cardiac death. Pediatric cardiac arrest, as I mentioned before, are mainly due to asphyxia, choking, shock, respiratory problems. Kids just kind of slide down the hill when they're going into cardiac arrest. They have a respiratory problem that decreases their breathing ability, and the heart gradually slows down until it comes to a stop. The way to fix it is start CPR and give them really good ventilations with lots of oxygen, and you can bring things back to normal there. So for your patient assessment, what we want to do is two levels here. We want to identify the cardiac arrest, try to figure out what's wrong that caused it, and then we need to be aware of what's going on around us to kind of get more clues as to what's going on with the patient in general. So we got a few pieces we got to put together really quick here. So the primary assessment, you find a patient that's unresponsive, no breathing, no pulse. That is your true definition of cardiac arrest. unresponsive, no breathing, no pulse, you start CPR. You need to get somebody on the chest as quick as possible within the first few seconds after you identify there's no pulse. With kids, infants, we have the sudden unexpected infant death syndrome. This includes SIDS, sudden infant death syndrome. We really don't know what causes it. There's a lot of coincidental um, common factors, like most SIDS babies. The parents, the mother is over 35. The mother has a history of smoking. The kids were placed in the bed face first, but we really don't know what happens. We do know that there's some issues with bedding being too soft. We do know his body position. We do know there's some blocked airway issues. But what we want to do is identify that there is a problem right away and start providing the treatment as quick as we can. It's usually sleep apnea, cardiac slowdown. They just quit breathing and go into cardiac arrest. So the problem here is most of it happens during their sleep, and the parents don't know it until the morning when they wake up and they find their kid is not is deceased in the bed. If you get to one of these, do everything you can to support the parents. There are times you may want to start cardiac resuscitation, even if you're not sure the patient is viable. If there is obvious rigor mortis, dependent lividity, um, things that just tell you there is no chance of survival, don't give the mom and dad extra hope. Go ahead and just call in to the physician advisor, tell them what's going on, and see if you can cease resuscitation right away. Get law enforcement involved, get the coroner involved, get professional help involved. Call the chaplain service if that's something you've got in your service. Offer to call family members, whoever you can. But biggest thing is now you've got 3 patients because you've got the child that was no longer resuscitatable, and now you've got 2 parents that you've got to support. So one thing we're doing is trying to improve our cardiac arrest survival in general. So we've got the chain of survival. 5 things we talk about in our book here is recognition and activation of the emergency response system, knowing there's an emergency, immediate high quality CPR, rapid defibrillation, basic and advanced EMS, and then advanced life support and post-arrest care. Once we get them back, now we've got to keep them back and get them back to a normal lifestyle. Big thing we're going to go on everything in EMS is making sure we have good teamwork and good coordination. So we're going to work together in groups to try to figure out how to get this coordination and teamwork for cardiac arrest. The first link in the chain of survival is recognition and activation of the EMS system. We want to get the call into 911 to get EMS en route, and then we want to provide that person some care before they get there. So we're training people to recognize cardiac arrest. Don't just step over the person. Actually do something. Reach down, check a pulse, shake them and shout. Call 911. Get the help on the way, and then start resuscitation. Most of our dispatchers will give you instructions over the phone on how to do CPR. They'll walk you through the whole process. One thing we need to do as EMTs and EMS in general is work on training the general public. In the YouTube channel, you can go to the supplements for this section and you'll find a video of an event that we did at Sky Sox Stadium a few years ago with Colorado Springs Fire Department and many other sponsors, where we trained 4,200 people in CPR that night. That's how you get more people trained in CPR. There's also a system called Pulse Point. It's sponsored by Zoll Medical. That you have an app on your phone, and if the area has a cardiac arrest and you're within 500 feet of that cardiac arrest, it alerts you on your phone and you have the option to go help. So we're getting people who are trained to go to the cardiac arrest. There's been twice that I've been in a restaurant where there was a cardiac arrest and I didn't realize it until the EMS showed up. And I could have been over there doing something to help out. So it's important to get people that are trained in the right place and to train those that don't usually need this type of care. We want high quality CPR. Push hard and fast in the center of the chest. New slogan for CPR is harder, deeper, faster. We want to push at least 100 times a minute, 100 to 120 times a minute. By doing this, we're pushing the blood from the chest into the cerebral area and into the heart muscle. The more oxygen we get into the brain and the heart muscle, the better the chance of survival. Hand placement is very important. We teach people the lower third of the patient's sternum. Used to be go to the xiphoid process, 2-finger width. Used to be nipple line. Lower third. Make it simple. Keep it as simple as possible. Knowing how many hands to put on the chest. You need to have enough contact with the chest that you can push it in 2 to 2.5 inches, or 1/3 the depth of the chest. If it's a adult, maybe 2 hands. If it's a child, maybe 1 hand. If it's a big child, 2 hands. If you're a strong person, a little adult, 1 hand. It's going to be up to you to figure out how much force you need to push on the chest. If it's an infant, we're using 2 fingers. If it's 2 rescuer, then we're going to use 2 thumbs, kind of putting your hands around the chest and squeezing the chest in at the same time. So there's some different ways to do it. We'll practice these in class, but it's important to get everybody on the same page and making sure all our community knows CPR. The depth is at least 2 inches, and it's key to let the chest rise after you're done with the compression. You want half the time on the downstroke, half the time in the upstroke. So, and on the infants and children, because it's harder to judge the depth, we're just going 1/3. Hands should overlap, locking fingers. There are no CPR police. So if you don't lock your fingers, you're okay. For your comfort, your elbows should be locked, so you can be using your shoulders to push up and down. You shouldn't be using your arm muscles to push. Your waist should be bending, not your elbows. So the other thing with CPR is we want to switch out every 2 minutes if at all possible. So the AEDs will shock every 2 minutes. So when they are attached and they say shocking, that's a time to switch out. We had some cardiac monitors at the fire department when I was there that would measure the quality of CPR. And we found almost all the time you had a decrease of at least the quality of CPR after about 2 minutes. So it was important to get that 2-minute switch out on all your cardiac arrest. Shows you the kind of positioning we look at. The fulcrum is at the hips, so you're using the hips to bend, and you're going up and down, straight up and down on the chest. Good CPR saves lives. Compression rate 100 to 120 a minute. You can use different songs to sing. Staying Alive is the one we hear all the time. Another one, Bites of Dust, although it's not one you want to sing out loud. It does have the same time frame. And the Imperial March from Star Wars has about the right time. So those are some good ones for you to do. Too slow, you don't get good compression, you get good circulation of the brain, and we really don't want we want to do that. And too fast, you don't have the time to refill. So you're looking for 100 to 120. We want a compression fraction of at least 90%. So that means only 10% of the time you're off the chest. So so you don't have to do calculations, no more than 10 seconds off the chest. If you're charging to defibrillate, you can do compressions. If you're analyzing, you shouldn't do compressions. If you're shocking, you shouldn't do compressions. If you're doing ventilations, you shouldn't do compressions. Every other time, you should be pressing on the chest. Pre-plan your change outs. Have somebody ready to go and step in. This is where you need somebody to step back and take charge and manage the cardiac arrest. They need to be the conductor and tell people who to do what. Um, Practice as a team. Look for who does what. This is one of the parts of the American Heart training video that you should have got to watch when you were doing your CPR class. Rescue breathing. If you're doing 2 rescuer CPR or 1 rescuer CPR, doesn't matter. You need to do 30 to 2 on adults. If it's pediatric and you're doing 2 rescuer, it's 15 to 2. The reason we go to less compressions to ventilation ratio is because they need more oxygen, like we discussed. We also have options for mechanical CPR devices. These are a very good tool. It's highly recommended by the American Heart Association, but the cost is around $15,000. So you're not going to get these at every service because of the expense that it takes. In the supplemental chapter or module 2 videos, you have the videos for these different devices. Highly encourage you to go look at those. One of the ones you see around our local community is the Lucas CPR device. You put the device on, it has a strap that goes around the patient, secures a plunger in the center of the chest, and it uses compressed air to make the plunger go up and down. Very efficient, very complete compressions. The other option is the Zoll Auto Pulse. It's a backboard with a strap that goes around, and it squeezes down on the chest and has circumferential compressions. You can defibrillate with these on, you can ventilate with these on. Some of them have built-in ventilation, some of them tell you when to ventilate. So know your system. Rapid defibrillation. When the heart goes into that sudden cardiac arrest, which is about 80 to 90% of the time, they go into VFib or VTAC. What the AED does is apply electricity to the bad cardiac rhythm, stops that rhythm long enough that hopefully the SA node can take over and create a normal heart rhythm again. So we want to get AEDs out there, everybody trained in them or at least aware of them, so they can grab them and use them at any time. They have 2 devices built into them. One is the little mini computerized paramedic that looks at the rhythm and tells you if it's VFib or VTAC. If it's VFib or VTAC, the defibrillator takes over and sends the electrical current through the patient. If it does not recognize VFib or VTAC, it will not arm the defibrillator. So it will not shock somebody that does not need it. Like we said, it hits the VFib, VTACs. Most important button on any defibrillator, no matter what the brand, is the on button. It's the big green button in the upper corner here. Some of them are so simple you just open the lid and it turns on. Once you turn it on, follow the instructions. It will tell you what's needed to be done. We have 2 types of AEDs. We have a monophasic AED, which sends a signal from the right shoulder to the left lower chest. It's one complete shock. Biphasic will actually send it from both pads at the same time and meet in the middle. So with this technology, you're sending half the energy that you would for the monophasic. The other advance we have on these biphasic defibrillators is we have impedance compensation. It measures the resistance between the 2 pads and adjusts the amount of shock given to the size of the patient. This allows it to give just enough shock to stop the heart without causing extra damage. So it goes down fairly small, but it still does not go down to a pediatric dose. For a pediatric patient, you have separate defibrillator pads that have a shock attenuator built into the pads, and it will reduce the shock down even further so that you don't over defibrillate a pediatric patient. If you do not have that pediatric adapter, you can use the adult size on a pediatric patient. If they need to be shocked, they need to be shocked. So it's okay to shock them a little bit too much because they can fix the damage later if they live. Link 4, the basic life support. We want to get trained EMS providers quickly there so that they can manage the situation, provide good compressions and good defibrillation. Once we get the advanced life support there, the AEMTs and paramedics, they can give medications to stabilize the heart and to fix the problems that cause the cardiac arrest and get the patient to the hospital so that we can resuscitate them back fully. What we want to do when we're there on scene is we establish this triangle of life. You've got one person doing compressions, one hooking up the AED, and one maintaining the airway. And then you have the fourth person being the uh, leader, kind of guiding what's going on, making sure that everybody's on the same page. And then they can also be aware of the surroundings. What is the family doing? What kind of information can I get from the family? And try to figure out what may cause the cardiac arrest, which will help you understand how to best resuscitate the person. The advanced life support and post-arrest care, once we get return of circulation, or a return of spontaneous circulation, or ROSC, ROSC, when the heart starts beating on its own, the patient starts to breathe. That is when we do some high fives real quick and then start stabilizing our patient. Make sure they have good oxygen, make sure they have a secured airway, and start moving forward. We need to get them to the hospital so they can do whatever interventions necessary to fix what caused the cardiac arrest. Maintain normal vitals. Call ALS. You need them there. Get a 12 lead EKG and maintain the airway. When we're managing cardiac arrest, you want to know when to do one person CPR and when to do the team based on your resources. You always use precautions. You don't do mouth to mouth anymore. You make sure you get the defibrillator hooked up. Call ALS. Get oxygen. Oxygen's really good for your cardiac arrest patients. Know when to move the patients. Have a plan on when you move them so that you're not stopping CPR any longer than necessary. Maintain the airway, add adjuncts if needed. And then the important thing is to interview the bystanders and family members. Understand what happened. How did you get to this point where you got the patient in cardiac arrest? Have a coordinated resuscitation team. So what this means is everybody works together. Everybody has a plan. You know who's going to switch around CPR. Make sure you have the right people there. ALS and BLS. You can't the survival rate goes up when you have a mixture of ALS and BLS. ALS has a very specific role in cardiac arrest, and BLS has a very specific role. You need to keep the blood flowing while they solve the problem that caused the cardiac arrest. Work as a team, have a team leader. Somebody needs to be in charge. Make sure everything's done in order the best you can. Have a plan when you get there. And then, like every good plan, it needs to be adjusted as things change. So identify the cardiac arrest patient. That's as simple as checking a pulse, checking breathing, determining you have neither, and then you've got a cardiac arrest patient. Start compressions. Get your team organized. Call for extra resources. Work on your patient where they lay. Remember, the more you move them, the more time you have before you're doing CPR. Get the AED hooked up as you're doing compressions. You don't have to stop CPR to hook an AED up. You can put the pads around where they are. Um, if you're alone, hook up the AED and then start the compressions. If you're with a child, we're going to do CPR first. This is again because they have respiratory problems that cause the cardiac arrest, not cardiac problems. AEDs fix cardiac problems. So if we can get the heart moving with oxygen and then to get the AED there, we might have something to shock. Showing good compressions and getting ready to hook up the pads. Notice it's a clean, bare, dry chest. Very important for hooking the AED up. Everything comes off. The chest is bare. If there's hair, shave it. We have AED or razors in our AED boxes. Biggest thing, and it's a test question on a few places, turn on the AED. That's the most important thing you can do. Follow the instructions on the pads. They have pictures. They show you where to put them. They're idiot proof. Any cop could figure out how to use these. Remove the clothing of your patient, the jewelry, medication patches. If you are removing medication patches, you really should have your gloves on because whatever's on that patch can be absorbed. So if you're getting a nitro patch, you get a dose of nitro and get your headache. If you get an estrogen patch, you get your dose of estrogen and you get moody. Trim the extra hair. Shave the chest if you have to. Wipe away the sweats and blood, liquids, all the blood. If the patient's in water, get them out of the water. Stop CPR and analyze. The machine will tell you, stop CPR, analyzing. As soon as it's done, it'll say, charging. You can do CPR while it charges. You only have to be off the chest while it's analyzing and while it's shocking. When it gets ready to shock, it'll tell you it's ready. And then you have to push the button to shock. Before you push the button to shock, you need to make sure that you're clear, your partner's clear, and everybody else is clear from the body. Because if you shock while they're touching, it will shock their heart and stop their heart too. So it's very important to get that in your habit of I'm clear, you're clear, everybody's clear before you shock. Push the big red flashing button, or orange, depending on the manufacturer. But you need to push it and make sure they're clear, or make sure they're clear and then push. As soon as the shock is done, you start CPR. You do not have to check a pulse. If you shock the heart, it is not going to jump right back up and start running. It's going to wait a second before the heart starts moving again. So we're going to do 2 minutes of CPR and give it time to get a rhythm built up before we check again. If you ever seen anybody get tased, they don't just get up and run. What we've done is tase the heart to shock the ventricles to make them stop and lets the normal part of the heart take over, the SA node. And so we're going to do CPR while it recovers and starts getting back in its normal rhythm. Here's the integration of the AED. You get the patient that's apneic pulseless. One person does CPR. The second person does the AED. Turn it on. Bear and attach. Clear the patient. Shock them. Or no shock advised. Go back to doing CPR. Very important to continuously do CPR on your patient. You breathe once every 30 compressions. Unless it's a child, then it's every 15 compressions. You have 2 good breaths. If you get an advanced airway, if you drop a gel in there, you can do 1 breath every 6 seconds. It doesn't matter on the compression rate. So you want to have good quality teamwork, good corrective comments. You don't have to hold back and let somebody do bad CPR. Say, hey, you're doing good. Push it faster. Push deeper. Check a pulse while they're doing CPR. You should feel a pulse. Remember, that's what we're trying to do is create a pulsation. So you should feel a pulse while they're doing compressions. If you have the resources available, start asking the medical history. What happened? Look for a secondary assessment to be done. Get the physical findings. Try to find out what's going on around the patient. Do a little investigating here to figure out what caused the cardiac arrest. Question continually comes up, should family members be allowed to watch the resuscitation? You need to make some decisions at the time of, but just understand that family members know what you're doing and understand the effort you're putting into saving their loved one if they're allowed to watch. A friend of mine did CPR on her husband. He was, I think, 32, and then she was allowed to watch the rest of the resuscitation. She knows that everything possible was done to try to save him. But if they would have been pushed out, she would have never known what was done. So it's up to you to make those decisions. If you see that the family members are getting upset or they're becoming extremely emotional or becoming disruptive to the scene, you can ask them if they can leave. But don't just let them take off on their own. Assign somebody to go with them. I always like to be the second crew in on a cardiac arrest because I can assign my partner to go help with the cardiac arrest and I can look for the family and kind of be with them and explain what's going on. They can understand what we're doing to try to save their loved one. And that gave them a little comfort. You do not jump in there and say, it looks like he's moving towards a light, or do you have a donor card? We need to know that right now. You give them encouraging information, but be honest with them. Say, we're doing everything possible. If it's successful, you got to shift to post-arrest care. Rapid transport, maintain airway, and call ALS. We need to get them to the advanced care levels as quick as possible. Check a pulse every 30 seconds. I think that's kind of long. If I've got brought them back from the dead, I want to make sure they still maintain a pulse. I'm going to probably assign somebody to keep their finger on their pulse and let me know if something changes. If no pulse is found, we start back at the beginning. Start with your ABCs, start CPR. If they're in a shockable rhythm, shock them right now. The heart's still good because they had a pulse and we just caught them again. And then follow the every 2 minutes for CPR and shocking. You can stop doing resuscitation if you have a couple things happen. If the patient asks you to stop, you can stop where you are. They say, ouch, that hurts. That's perfectly fine to stop. You get the spontaneous respirations. Start doing back valve mask. Or if you get spontaneous circulation. If you get spontaneous circulation and breathing, you just support them and make sure they're taken care of. If somebody else of equal or greater training takes over, you can stop. You turn the care over to a person with higher level of training. That's what we want. You're too exhausted to continue. You've been doing CPR for an hour and you just physically cannot go on anymore. It is perfectly fine to stop the resuscitation process. Certain systems have plans in place. If you get a cardiac arrest and you've done 20 minutes of care with shocks and you've got to the point of no shock advised for a set number of times, you can call the physician on the medical control and ask for permission to stop resuscitation. The goal here is to get return to circulation. If we don't get that in the first 20, 30 minutes, we're not going to get it no matter what we do with the patient. So we're going to reduce our risk of injury and not transport the patient to a hospital. If resuscitation is not successful, you're going to have to let the family know. Don't sugarcoat it. Don't add things that you don't know. Basic information is we've done a lot of things to try to revive your loved one. Unfortunately, they did not respond to anything we did, and we've had a conversation with our physician, and they feel that it's best at this time to just go ahead and cease resuscitation. We're so sorry for your loss. You can let the family in with the deceased. Now, because if it's outside of a hospital, there are some law enforcement issues they've got to work through. So I would always ask the law enforcement at scene if they can be around the patient. If you suspect anything is strange, kind of keep them away until law enforcement gets there. Um, you need to be patient with them. Ask if they have some type of spiritual care person they would like you to call, or if you can call your fire department or police or ambulance chaplain to come help. Uh, just be honest with them. I've had to tell way too many people that their loved one is deceased. Uh, Being in a small town, you end up knowing a lot of them or have connections. So uh, it's never easy, but it's relieving to know that you're the one that gave them that last opportunity to be with their friend, their family, their loved one. So it's part of the job, and we deal with it. Special consideration. If you get there and the bystanders have AEDs on your patient, let them go ahead and finish a round, and when the AED shocks, then you take over. Maybe you leave it connected to their AED, maybe you hook up yours. Depends on what you have going on. Some AEDs we take to the hospital so we can keep an eye on what's going on. They can download the data. Most of them we just leave at the scene. If you're in the ambulance, you should try to stop the ambulance. If you're doing defibrillation with an AED, it can pick up the road noise as interference and it will not shock. So you want to stop the ambulance and turn off the engine so you can analyze. Once you do that, hopefully you've asked for ALS because they do not have to stop the ambulance to shock. It's just your AEDs, your automated external defibrillators, that get confused. If you have a patient that has been in cold water or they've been outside in the cold, we're going to have some special challenges with resuscitation. And just so you know, every body of water in Colorado, or at least our area, is considered cold water drowning. Even in the summertime, it's cool enough that we'll get hypothermia on our patients. So we're going to resuscitate them until we warm them up. If their temp is below 86 degrees Fahrenheit, the core temp, you're not going to get a good defibrillation. The heart will not respond to shocking. So what we want to do is quality CPR, and we're going to transport them to the facility most appropriate and shock as we can. But you're going to keep going. One of my EMT students was telling me that his brother had been under the ice for 60 minutes before they found him, brought him out and resuscitated him, and he had no deficits at all. He even brought the articles in from the newspaper to show us that how long it had been, and it was 60 minutes he was under the ice. So there is documented cases where people have survived from being underwater and in a cold environment because it chills the brain and puts them in hibernation basically, and then we can bring them back to life. Treat them just as any other cardiac arrest, good quality CPR, airway management, and then make sure you're being careful with the wet patients with defibrillation. There was a rescue show back in the 90s where they would defibrillate in the water, um, and that's not the safest option. Electricity will go through the water and cause a shock to you too. So get them out of the water, onto the shore, onto the boat, onto a backboard, and you're fine. If you're on ice, it doesn't conduct the electricity very good, so you're safe there. And if you're just on a wet surface, like wet grass, you'll be fine too. It's where you're in standing water that you get the conductivity. Do not defibrillate a soaking wet patient. You're going to dry them off. The pads won't stick unless you do. Remove medication to prevent burning. They don't burn. Implants and surgeries. If a patient has an implanted defibrillator and they're in cardiac arrest, you have just proved to yourself that the defibrillator is not working. If it was working, they wouldn't be in cardiac arrest. So what we want to do is attach the pads to the patient. We do not put the pads directly over the device underneath the skin. It looks about the size of a skull can underneath the skin, so it looks like the back pocket of a cowboy. And so you just move it to the side, just in the same area, but not sitting directly on top of it, and to let the machine go just like normal. You may see pacemakers could be implanted, defibrillators. We're going to talk about the ventricular assist devices. These are uh, they pull the blood out into a pump on the outside and bypass the left ventricle and then push the blood back into the aorta. You do not have to defibrillate these. You do not have to do anything. If they've got that left ventricular assist device, then that is their heart. So the only way they would go into cardiac arrest is if their battery dies, and there's a hand crank on it. So you have to crank it, I think, 60 times a minute. I'd have to look at that or read the instructions when you get there. So as with always, if you have questions, stories, ideas, things you want to discuss, bring them to class. Happy to have a chat with you. So have a great night. Thanks, guys.